What are the key considerations for resuscitating a pregnant patient in cardiac arrest, and how do these considerations differ from standard adult resuscitation protocols? Answer: when resuscitating a pregnant patient, especially in the later stages of pregnancy, certain modifications to standard ACLS protocols are essential due to the physiological changes and potential risks to both the mother and fetus. A maternal positioning: it is critical to position the patient appropriately to avoid inferior vena cava compression. The left lateral tilt should be employed to improve venous return and cardiac output. If spinal immobilization is required, use a wedge or manually displace the uterus to the left side. Pharmacological considerations: medications such as epinephrine can be used during cardiac arrest, however, dosages may need to be reassessed based on maternal weight. Continuous monitoring of the maternal and fetal heart rates during the resuscitation process is vital. Timing of delivery: if the mother does not regain a pulse after 4 or 5 minutes of effective resuscitation, consider performing an emergency cesarean section (C-section) to potentially save the fetus, especially if the gestational age is advanced. This intervention is based on the concept that prolonged cardiac arrest can lead to fetal demise. Team dynamics: the resuscitation team should include personnel trained in obstetric emergencies to manage potential complications and provide immediate post-resuscitation care for both mother and child. Relevant guidelines: these considerations are outlined in the ACLS guidelines published by the American Heart Association and emphasize the importance of addressing both maternal and fetal safety during resuscitation efforts. A 10-year-old child presents with severe respiratory distress and altered mental status after near-drowning incident. What initial assessment and management steps should be taken in this situation? Answer: in the management of a pediatric near-drowning victim, the following steps should be taken promptly. Initial assessment: FDA approach. Airway: ensure the airway is clear. If there are signs of airway obstruction, perform necessary maneuvers to open the airway, such as the head tilt, chin lift, or jaw thrust maneuver. Breathing: assess for adequate breathing. If absent or inadequate, provide rescue breaths using a bag mask device. High flow oxygen should be administered if the child is hypoxic. Circulation: check for pulse and signs of circulation. If absent, initiate high-quality CPR. 30 compressions followed by 2 breaths. Disability: evaluate the child's level of consciousness using the AVPU scale. Alert, verbal, pain, unresponsive. Perform a quick neurological assessment. Exposure: remove wet clothing to prevent hypothermia, but ensure that the child is adequately warm. Management considerations: fluid resuscitation: administer IV fluids judiciously if signs of shock are present. Hypothermia management: if the child is hypothermic, follow rewarming protocols, but avoid rapid rewarming to prevent cardiovascular instability. Monitoring: continuous monitoring of vital signs, cardiac rhythm, and oxygen saturation is crucial. Be vigilant for potential complications like aspiration pneumonia and secondary drowning. Relevant guidelines: guidelines provided by the AHA emphasize the importance of immediate airway management and resuscitation in drowning victims, particularly the nuances in pediatric patients. In a case of suspected opioid overdose, what assessment findings would confirm this diagnosis and what immediate interventions should be taken? Answer: in suspected opioid overdose, the following assessment findings are critical. Classic signs: altered mental status. The patient may present as unresponsive or drowsy. Respiratory depression. Look for shallow, slow breathing, less than 12 breaths per minute. Miosis. Pinpoint pupils are characteristic of opioid use. Initial interventions: call for help, activate emergency medical services immediately. Airway management: ensure the airway is patent. Provide rescue breaths if the patient is apneic. Administer naloxone. If opioid overdose is suspected, administer naloxone, Narcan. The typical initial dose for adults is 0.4 mg to 2 mg of M. Repeat every 2-3 minutes as needed up to 10 mg. In pediatric patients, the dosage may vary based on weight. Post-resuscitation care: once the patient responds, monitor for potential recurrent respiratory depression, as the effect of naloxone may wear off before the opioid. Transport to a medical facility is essential for further evaluation and care. Relevant guidelines: the management of opioid overdose is governed by the AHA guidelines and protocols for the use of naloxone in emergency situations. Mr. Thompson, a 72-year-old man, presents to the emergency department with severe hypothermia, core temperature of 28 deg. What steps should the healthcare team take to manage his condition effectively? Answer: in managing severe hypothermia, particularly in elderly patients like Mr. Thompson, the following steps are essential. Immediate assessment: confirm the core temperature using an esophageal or rectal thermometer for accuracy. Assess for signs of cardiac instability, bradycardia, hypotension. Active rewarming strategies: Remove wet clothing and replace with dry, warm coverings to prevent further heat loss. Use warm IV fluids. Administer IV fluids warmed to 42D GC to facilitate rewarming. External rewarming devices. Employ external warming blankets or heat packs on the axilla, groin, and neck. Monitoring and advanced care. Continuous cardiac monitoring. Be vigilant for arrhythmias, which are common in hypothermic patients due to electrolyte imbalances. Avoid rapid rewarming. Do not use direct heat e.g. hot water bottles to prevent burns or cardiac complications from vasodilation. Consideration of CMO or CPB. In severe cases where standard rewarming is insufficient, consider advanced techniques such as extracorporeal membrane oxygenation (ECMO) or cardiopulmonary bypass (CPB) for rewarming and hemodynamic support. Relevant guidelines. The AHA and Wilderness Medical Society provide comprehensive guidelines on the management of hypothermia, emphasizing gradual rewarming and monitoring for complications. Explain the physiological changes that occurred during cardiac arrest and how they impact the effectiveness of CPR. Answer: during cardiac arrest, the following physiological changes occur that significantly impact CPR effectiveness. Loss of cardiac output. The heart fails to pump blood effectively, leading to decreased systemic and coronary perfusion. This reduction in blood flow means that vital organs, including the brain and heart, do not receive adequate oxygen. Hypoxia and acidosis. Without effective circulation, tissues undergo anaerobic metabolism, resulting in hypoxia and the production of lactic acid. Metabolic acidosis can further impair cardiac function and responsiveness to CPR. Increased intrathoracic pressure. High-quality chest compressions create positive intrathoracic pressure, which facilitates blood return to the heart. Inadequate compressions can lead to insufficient venous return and decreased blood flow during diastole. Coronary perfusion pressure (CPP). The effectiveness of CPR depends significantly on maintaining CPP, which is essential for the heart's ability to generate a return of spontaneous circulation (ROSC). Reperfusion injury. If ROSC is achieved, the sudden restoration of blood flow can cause reperfusion injury characterized by oxidative stress and inflammation. What are the critical components of managing hypothermia in a patient, and how do these differ from hypothermia management protocols? Answer: in managing hypothermia, the following critical components must be considered. Recognition of symptoms. Hypothermia may present as confusion and agitation and flushed skin. The core temperature is typically above 38 to 100.4 deg. Immediate cooling strategies. Remove the patient from the heat source and relocate them to a cooler environment. Use of cold packs. Apply cold packs to major vascular areas, including the neck, armpits, and groin. Evaporative cooling. Use cool mist or fans to facilitate evaporative cooling if the patient is conscious and able to tolerate it. Hydration. Administer IV fluids to rehydrate the patient. Cold intravenous fluids may help to lower core temperature more effectively. Monitoring. Continuous monitoring of vital signs, especially temperature and heart rate, is crucial to assess the effectiveness of cooling strategies. Consideration of medications. In cases of heat stroke with severe symptoms, medications such as benzodiazepines may be indicated to control agitation or seizures. Differences from hypothermia management. Unlike hypothermia, where rewarming must be gradual to avoid cardiovascular instability, hypothermia management focuses on rapid cooling to prevent complications such as heat stroke. In hypothermia, the focus is on fluid resuscitation to prevent dehydration, whereas in hypothermia, fluid resuscitation must be done cautiously as rapid rewarming can lead to shock. Relevant guidelines. The AHA and other medical organizations provide guidelines that outline the management of hypothermia, emphasizing the importance of early recognition and aggressive cooling measures. Mr. Lee, a 55-year-old man with a history of chronic alcoholism, is found unconscious in his home. His friends report he had been drinking heavily for the past 24 hours. What immediate actions should the emergency team take upon his arrival? Answer: upon Mr. Lee's arrival at the emergency department, the emergency team should take the following immediate actions. Primary assessment of the approach. Airway. Ensure his airway is open. If he is unresponsive, consider airway adjuncts such as oropharyngeal or nasopharyngeal airways. Breathing. Assess for adequate breathing. Administer supplemental oxygen if hypoxic. Circulation. Check for pulse and initiate high-quality CPR if there is no pulse. Naloxone administration. Given his history of heavy drinking, it is essential to consider potential co-ingestion of opioids. Administer naloxone as it can reverse opioid effects and monitor for any response. Intravenous access and fluid resuscitation. Establish IV access and administer IV fluids to prevent dehydration and manage potential hypovolemia. Thiamine supplementation. Administer thiamine, vitamin B prophylactically to prevent Wernicke's encephalopathy, a common complication in chronic alcohol users. Monitor vital signs. Continuous monitoring of vital signs is crucial to detect any deterioration in his condition. Relevant guidelines. The management protocols for acute alcohol intoxication and the administration of thiamine are supported by the AHA and other emergency care guidelines. Discuss the differences in medication dosing and protocol modifications for pediatric versus adult patients during ACLS, particularly in cases of cardiac arrest. Answer. When administering ACLS for pediatric versus adult patients, several key differences in medication dosing and protocol modifications must be considered. Medication dosing. Epinephrine. For adults, the standard dose is 1 mg IVO every 3-5 minutes. In pediatric patients, the dose is based on weight 0.1 mg IVO with a maximum single dose of 1 mg miodarone. In adults, the initial dose is 300 mg IVO followed by 150 mg if needed. For pediatric patients, the dosing is for mdg up to 300 mg total. Defibrillation energy levels. For adult patients, the initial shock should be 2.0 joules biphasic or 360 joules monophasic. In children, the recommended initial shock is 4 joulesque with subsequent shocks at 4 joulesque. Protocols. Airway management. Pediatric patients may require different airway adjuncts due to size and anatomy. The use of bag mask ventilation should be adjusted to fit the patient's facial dimensions. Chest compressions. The depth of compressions differs. For children, compressions should be about 1/3 the depth of the chest, approximately 1.5 inches for infants and 2 inches for older children, whereas for adults it should be at least 2 inches deep. Team approach. Pediatric resuscitation often requires a multidisciplinary team approach with roles clearly defined, given the unique physiological differences and emotional support needed for both the child and their family. Relevant guidelines. The AHA Pediatric Advanced Life Support (PALS) guidelines provide comprehensive recommendations for pediatric resuscitation, emphasizing the importance of appropriate dosing and technique adjustments. Describe the role of team dynamics in ACLS scenarios and how effective communication can impact patient outcomes during resuscitation efforts. Answer. Team dynamics play a critical role in the success of ACLS scenarios, particularly in high-stress situations like cardiac arrest. Key components include defined roles. Each team member should have clearly defined roles based on their skills and expertise. E.g., team leader, airway manager, compressor. This clarity ensures that everyone knows their responsibilities and can act quickly. Effective communication. Open lines of communication are essential. Use closed-loop communication techniques where instructions are repeated back for confirmation. This reduces the risk of errors and enhances coordination during interventions. Regular briefings. Before starting resuscitation efforts, a brief huddle or debriefing can help align the team's understanding of the situation and establish a shared mental model. Situational awareness. Team members should maintain awareness of the patient's condition and changes in the environment, enabling rapid adjustments to the resuscitation strategy. Feedback mechanisms. Constructive feedback should be encouraged to continuously improve team performance. After the code, conduct a debriefing to discuss what went well and identify areas for improvement. After successfully resuscitating a patient in cardiac arrest, the medical team must ensure proper post-cardiac arrest care. Discuss the goals of post-resuscitation care and how they are assessed in practice. Answer. Team dynamics play a critical role in the success of ACLS scenarios, particularly in high-stress situations like cardiac arrest. Key components include defined roles. Each team member should have clearly defined roles based on their skills and expertise. E.g., team leader, airway manager, compressor. This clarity ensures that everyone knows their responsibilities and can act quickly. Effective communication. Open lines of communication are essential. Use closed-loop communication techniques where instructions are repeated back for confirmation. This reduces the risk of errors and enhances coordination during interventions. Regular briefings. Before starting resuscitation efforts, a brief huddle or debriefing can help align the team's understanding of the situation and establish a shared mental model. Situational awareness. Team members should maintain awareness of the patient's condition and changes in the environment, enabling rapid adjustments to the resuscitation strategy. Feedback mechanisms. Constructive feedback should be encouraged to continuously improve team performance. After the code, conduct a debriefing to discuss what went well and identify areas for improvement. In the context of drowning and asphyxia, what are the essential management steps for a patient who has been submerged for an extended period? Answer: management of a patient who has experienced drowning and potential asphyxia for an extended period involves several critical steps. Immediate assessment. Conduct a rapid primary assessment at the approach upon arrival at the scene. Look for signs of respiratory distress, altered mental status, or absence of vital signs. Rescue breathing. If the patient is apneic but has a pulse, initiate rescue breathing. Deliver breaths at a rate of 1012 breaths per minute, ensuring each breath makes the chest rise visibly. Initiate CPR. If there is no pulse, immediately start high-quality CPR with chest compressions at a rate of 100-120 compressions per minute. Use a compression to ventilation ratio of 30. 2. Fluid management. Administer IV fluids judiciously if the patient exhibits signs of shock, but be cautious not to overload the patient, especially if pulmonary edema is present. Advanced monitoring. Continuous monitoring of vital signs, including cardiac rhythm, is essential. Post-resuscitation care. Once our OSC is achieved, provide supportive care, including oxygen therapy and temperature regulation, to prevent complications from prolonged hypoxia. Explain the significance of continuous ECG monitoring in post-cardiac arrest care and describe the types of arrhythmias that may be observed during this period. Answer: continuous ECG monitoring is vital in post-cardiac arrest care as it allows for real-time assessment of the heart's rhythm and function. It helps identify potentially life-threatening arrhythmias which can occur due to myocardial ischemia, electrolyte imbalances, or reperfusion injury. Common arrhythmias that may be observed include ventricular fibrillation, VF, a chaotic electrical activity that leads to ineffective contraction of the heart muscle requiring immediate defibrillation, ventricular tachycardia, VT, a fast heart rhythm originating from the ventricles that may deteriorate into VF if not treated promptly. Atrial fibrillation, AF, a rapid, irregular rhythm that can increase the risk of stroke and other complications. Asystole, the absence of electrical activity in the heart indicating a lack of effective cardiac output. Early recognition and appropriate management of these arrhythmias are crucial for improving patient outcomes. A patient has been resuscitated from cardiac arrest and is showing a GCS score of 8. What does this indicate, and what are the next steps in neurological assessment? Answer: a Glasgow Coma Scale (GCS) score of 8 indicates a severe level of impairment in consciousness, which typically classifies the patient as being in a comatose state. The GCS consists of 3 components: eye-opening, verbal response, and motor response. A score of 8 means the patient has limited eye-opening, often to pain, no coherent verbal response, and may exhibit flexor posturing or no movement in response to stimuli. Next steps in neurological assessment should include comprehensive neurological examination. Assess pupillary response, limb movement, and any reflexes to gather more information about brain function. CT or MRI scans. Imaging may be indicated to evaluate for any structural brain injury or hemorrhage. Continuous monitoring. Frequent reassessment of the GCS and vital signs to track any changes in neurological status, allowing for timely intervention if deterioration occurs. Therapeutic hypothermia protocols. If not already initiated, consider whether the patient qualifies for TTM based on their clinical status and hospital protocols. Mr. Thompson is a 62-year-old male who was successfully resuscitated after witnessed cardiac arrest due to myocardial infarction. After stabilizing his hemodynamics, he remains unresponsive with a GCS of 6. What immediate actions should the medical team take to manage his condition effectively? Answer: given Mr. Thompson's unresponsive state and GCS of 6, the medical team should take the following immediate actions. Initiate targeted temperature management, TTM. As he remains unresponsive post-resuscitation, it is critical to implement TTM to mitigate potential neurological damage. This involves cooling the patient to a target temperature between 30°C to 36°C, monitoring for any complications during the cooling process. Perform comprehensive neurological assessment. Conduct a detailed examination to evaluate for any signs of recovery or deterioration in neurological function. Continuous ECG monitoring. Begin continuous cardiac monitoring to identify any arrhythmias that could arise, especially given his history of myocardial infarction. Prepare for possible interventions. Given the GCS of 6, the team should be ready for potential interventions such as advanced airway management to ensure adequate ventilation and oxygenation. Consultation with neurology. Engage neurology specialists for a more comprehensive evaluation and management plan based on his neurological status. Discuss the indications for therapeutic hypothermia in post-cardiac arrest care and the protocols involved in cooling and rewarming the patient. Answer: therapeutic hypothermia is indicated in patients who remain comatose following resuscitation from cardiac arrest, particularly in cases of ventricular fibrillation (VF) or pulseless ventricular tachycardia (VT) as the initial rhythm. The primary goals are to reduce metabolic demands and preserve neurological function. Protocols for TTM include cooling phase. Initiate cooling within 6 hours of the return of spontaneous circulation (ROSC). Use active cooling methods, such as cooling blankets or endovascular cooling devices, to achieve a target temperature of 32 deg to 36 deg, 89.6 deg to 96.8 deg. Monitor the patient continuously for shivering and manage it with sedation or paralytics as necessary. Maintenance phase. Maintain the target temperature for 24 hours. Closely monitor vital signs, electrolyte levels, and the patient's neurological status during this period. Rewarming phase. Gradually rewarm the patient at a rate of 0.25 deg to 0.5 deg per hour to avoid complications such as rebound hypothermia or electrolyte imbalances. Continue to monitor the patient's neurological and hemodynamic status during this phase. Describe the importance of monitoring vital signs in the post-cardiac arrest phase and outline the key vital signs that must be assessed. Answer: monitoring vital signs in the post-cardiac arrest phase is critical for detecting changes in a patient's hemodynamic status and guiding further interventions. Vital signs provide essential information about the effectiveness of resuscitation efforts and the patient's response to treatment. Key vital signs to assess include heart rate and rhythm, continuous ECG monitoring helps identify arrhythmias and provides insight into cardiac function. Blood pressure. Monitoring blood pressure is crucial for assessing hemodynamic stability. The use of invasive arterial lines may be necessary for continuous blood pressure readings in critically ill patients. Respiratory rate and oxygen saturation. Adequate ventilation and oxygenation are vital for recovery, especially if the patient is on mechanical ventilation. Temperature. Monitoring body temperature is essential, particularly when therapeutic hypothermia is employed to manage cooling and rewarming protocols effectively. What are the critical components of post-resuscitation care that must be prioritized to improve outcomes for patients who have experienced cardiac arrest? Answer: the critical components of post-resuscitation care that must be prioritized include hemodynamic stabilization, ensuring adequate blood flow to vital organs through fluid resuscitation and the use of medications such as inotropes or vasopressors as necessary. Continuous monitoring of vital signs and the use of invasive monitoring techniques can help guide these interventions. Neurological recovery assessment. Ongoing evaluation of the patient's neurological status using standardized scales like the GCS, as well as assessment of pupil responses and limb movement, can help determine the extent of recovery and guide further treatment options. Therapeutic hypothermia. Implementation of TTM protocols for comatose patients post-cardiac arrest can significantly improve neurological outcomes. Multidisciplinary care approach. Collaboration among healthcare providers, including emergency physicians, neurologists, intensivists, and nursing staff, is essential for managing the complexities of post-cardiac arrest care. Family communication and support. Providing timely updates and support to the patient's family is vital, as they play an important role in the recovery process and may need guidance on what to expect during the post-resuscitation phase. Discuss the role and significance of invasive monitoring techniques, such as arterial lines, in the management of post-cardiac arrest patients. Answer: invasive monitoring techniques, particularly arterial lines, play a crucial role in the management of post-cardiac arrest patients by providing continuous and accurate measurements of blood pressure and facilitating blood gas analysis. The significance of arterial lines includes continuous blood pressure monitoring. Arterial lines allow for real-time monitoring of systemic blood pressure, which is vital for assessing hemodynamic stability and guiding treatment decisions, particularly in patients who may require rapid adjustments to fluid or medication therapy. Frequent blood sampling. The ability to obtain blood samples for arterial blood gas analysis without repeated needle punctures enables prompt assessment of oxygenation, acid-base balance, and electrolyte levels, identifying hemodynamic instability. Invasive monitoring helps detect early signs of complications such as shock or cardiac dysfunction, allowing for timely intervention and optimization of therapy. Guiding fluid and medication administration. Continuous monitoring can inform decisions regarding fluid resuscitation and the use of vasoactive medications, ensuring that the patient receives appropriate therapy based on real-time hemodynamic data. What clinical signs should healthcare providers look for to determine potential neurological recovery in post-cardiac arrest patients? Answer: to assess potential neurological recovery in post-cardiac arrest patients, healthcare providers should monitor for the following clinical signs. Improvement in Glasgow Coma Scale (GCS) score. An increase in the GCS score over time indicates improving consciousness and responsiveness. A score of 8 or higher typically suggests better neurological function. Pupillary reaction. Reactivity of the pupils to light can indicate brainstem function and is a positive sign of neurological recovery. Fixed or dilated pupils may suggest poor prognosis. Movement and responsiveness. Spontaneous movement, purposeful responses to stimuli, e.g., withdrawal from painful stimuli, and any signs of following commands are encouraging indicators of neurological recovery. Verbal response. The ability to verbalize, even if incoherent, is a sign of improving cognitive function. The emergence of coherent speech is particularly significant. Corneal and gag reflexes. The presence of these reflexes indicates functioning cranial nerves and suggests that the brain is regaining function. Electroencephalogram findings, EEG monitoring may reveal activity that indicates neurological recovery, such as organized brain activity or responses to stimuli. What factors should clinicians consider when deciding to implement therapeutic hypothermia in a post-cardiac arrest patient, and what are the contraindications? Answer: clinicians should consider the following factors when deciding to implement therapeutic hypothermia in a post-cardiac arrest patient. Neurological status. Therapeutic hypothermia is indicated for patients who are comatose after cardiac arrest with an initial rhythm of VF or VT. The patient's level of consciousness is a key consideration. Time from cardiac arrest to initiation. Ideally, cooling should commence as soon as possible after the return of spontaneous circulation, ROSC, ideally within 6 hours. Underlying cause of arrest. Etiology of the cardiac arrest, e.g., myocardial infarction, drowning, may influence the decision. Hypothermia is more beneficial in certain contexts. Patient stability. The patient's hemodynamic stability and the ability to manage potential complications, e.g., coagulopathy, infection risk, must be assessed before initiating TTM. Contraindications for therapeutic hypothermia include severe coagulopathy. Increased risk of bleeding may preclude the use of hypothermia. Active systemic infection. Hypothermia can exacerbate the risk of infection or complicate management. Pregnancy. Safety and efficacy in pregnant patients remain less established. Pre-existing neurological conditions. Patients with significant pre-existing neurological impairment may not benefit from hypothermia. Careful assessment of these factors will guide clinicians in making informed decisions about the implementation of therapeutic hypothermia. What is the significance of the FAST assessment in stroke recognition, and how does it guide immediate management? Answer: the FAST assessment, which stands for face drooping, arm weakness, speech difficulties, and time to call 911, is critical for the rapid identification of stroke symptoms. Its significance lies in the fact that timely recognition of stroke can drastically affect outcomes, as interventions are most effective when administered within a specific time frame, particularly for ischemic strokes where thrombolytic therapy is indicated. Face drooping. Assess if one side of the face droops or is numb. Arm weakness. Check if one arm drifts downward when raised. Speech difficulties. Evaluate if the person speaks slurred or has trouble speaking. When any of these symptoms are present, it indicates a possible stroke and necessitates immediate emergency response. According to the American Heart Association, AHA, treatment with IV thrombolytics, such as tissue plasminogen activator (EPA), should be initiated within 3 to 4.5 hours from symptom onset. Promptly calling 911 ensures that the patient receives critical care and transport to a medical facility equipped for stroke intervention. Explain the difference between ischemic and hemorrhagic strokes in terms of etiology, clinical presentation, and management strategies. Answer: strokes can be classified as ischemic or hemorrhagic based on their underlying etiology. Ischemic stroke etiology, caused by a blockage in a blood vessel supplying blood to the brain, often due to thrombosis or embolism. Clinical presentation. Symptoms may include sudden weakness, confusion, trouble speaking, and loss of balance. Management strategies. Immediate treatment may involve thrombolytic therapy if within the treatment window. Other strategies include anticoagulation therapy and addressing risk factors, e.g., hypertension, diabetes. Hemorrhagic stroke etiology. Results from the rupture of a blood vessel leading to bleeding in or around the brain. Common causes include hypertension and aneurysms. Clinical presentation. Symptoms may include a sudden severe headache, nausea, and altered consciousness. Management strategies focus on controlling bleeding, which may involve surgical intervention along with the management of intracranial pressure. Long-term care includes blood pressure control and rehabilitation. Understanding these differences is crucial for appropriate intervention and treatment planning. In the context of acute ischemic stroke, what are the eligibility criteria for administering IV TPA and what monitoring is necessary post-administration? Answer: the eligibility criteria for administering IV TPA, tissue plasminogen activator, in cases of acute ischemic stroke include inclusion criteria: age 18 years or older, clinical diagnosis of an ischemic stroke, onset of symptoms within the last 3 to 4.5 hours, evidence of a measurable neurological deficit. Exclusion criteria: active bleeding or significant head trauma within the past 3 months, prior intracranial hemorrhage or a history of a serious hemorrhagic stroke, recent surgery or trauma that increases bleeding risk. Post-administration monitoring includes observing for signs of bleeding, neurological assessment every 15 minutes for the first 2 hours, then every 30 minutes for the next 6 hours, and then hourly for 24 hours. Blood pressure should be maintained under 180-105 mmHg to reduce the risk of hemorrhage. A scenario involves Mr. Thompson, a 67-year-old male who suddenly presents with slurred speech and right-sided weakness. What immediate actions should the healthcare team take to assess and manage his condition? Answer: in the case of Mr. Thompson, the healthcare team should follow these immediate actions. Rapid assessment. Use the FAST assessment to confirm the presence of symptoms indicating a stroke. Call for emergency services. Activate the emergency response system for immediate transport to a stroke-capable facility. Obtain vital signs. Monitor blood pressure, heart rate, and oxygen saturation. Perform a neurological examination. Assess the Glasgow Coma Scale (GCS) and document the neurological deficits. Initiate IV access. Prepare for potential administration of IV TPA or other treatments upon arrival at the hospital. Gather history. Obtain a detailed medical history, including onset time of symptoms and any contraindications for thrombolytics. Timely intervention can significantly impact the prognosis and outcomes for Mr. Thompson. Discuss the role of post-stroke care in enhancing recovery outcomes. What strategies are employed in early rehabilitation? Answer: post-stroke care plays a pivotal role in enhancing recovery and minimizing long-term disability. Key components include early rehabilitation. Initiating rehabilitation as soon as the patient is stable is crucial. This may involve physical therapy, occupational therapy, and speech therapy tailored to the patient's specific deficits. Neurological assessments. Regular assessments help to monitor progress and adjust rehabilitation strategies accordingly. Risk factor modification. Educating patients about lifestyle changes to manage hypertension, diabetes, and hyperlipidemia is essential for preventing future strokes. This can include dietary counseling, exercise plans, and medication adherence. Psychosocial support. Providing mental health resources and support groups can help address emotional challenges that arise post-stroke. By implementing these strategies, healthcare providers can optimize recovery and improve the quality of life for stroke survivors. What are the common signs of stroke, and how can healthcare professionals effectively educate the public on recognizing these signs? Answer: common signs of stroke include sudden numbness or weakness in the face, arm, or leg, especially on one side, confusion or difficulty understanding speech, trouble speaking or slurred speech, sudden trouble seeing in one or both eyes, sudden difficulty walking, dizziness or loss of balance. Healthcare professionals can effectively educate the public by community workshops, organizing sessions to discuss stroke signs, symptoms, and the importance of rapid response, informational materials, distributing brochures or flyers in clinics and community centers detailing the FAST assessment, social media campaigns, utilizing social media platforms to spread awareness and share real-life stories of stroke survivors, partnerships, collaborating with local organizations and hospitals to host events that raise awareness of stroke prevention and recognition. Explain the critical role of the American Heart Association (AHA) guidelines in stroke management and care. Answer: the American Heart Association (AHA) provides evidence-based guidelines for the management of stroke that are crucial for ensuring optimal care. Key roles include standardization of care. AHA guidelines establish standardized protocols for the assessment, diagnosis, and treatment of stroke, promoting consistent care across healthcare settings. Timeliness of intervention. Guidelines emphasize the importance of rapid evaluation and treatment, outlining specific timeframes for administering therapies like TPA and recommending protocols for identifying stroke types. Quality improvement. AHA guidelines support quality improvement initiatives by providing benchmarks and performance measures for hospitals and healthcare systems. Ongoing research. The AHA continuously updates its guidelines based on the latest research, ensuring that healthcare providers have access to current best practices for stroke management. Adhering to AHA guidelines helps reduce morbidity and mortality associated with strokes, improving overall patient outcomes. What specific educational measures should be taken for stroke survivors to prevent recurrence and enhance long-term outcomes? Answer: to prevent recurrence and enhance long-term outcomes for stroke survivors, specific educational measures should include medication adherence, educating patients about the importance of taking prescribed medications such as anticoagulants and antihypertensives consistently, lifestyle modifications, counseling on diet, physical activity, and smoking cessation to mitigate risk factors such as obesity, hypertension, and diabetes. Regular follow-up care, encouraging scheduled follow-up visits with healthcare providers to monitor health status and adjust treatment plans as necessary. Recognizing warning signs, training patients and their families to recognize the early signs of stroke and understand when to seek immediate medical attention. Support resources, providing information about support groups and rehabilitation resources to help patients manage the emotional and psychological effects of stroke. These measures empower stroke survivors and their families to take proactive steps toward recovery and prevention. Describe the importance of neurological assessments during the post-stroke care phase and the specific tools used for these assessments. Answer: neurological assessments during the post-stroke care phase are vital for monitoring recovery. Regular assessments help track the patient's progress and determine the effectiveness of rehabilitation efforts. Identifying complications. Early detection of complications such as new strokes, seizures, or infections can significantly impact patient outcomes. Guiding rehabilitation plans. The findings from neurological assessments guide the customization of rehabilitation programs to address specific deficits. Common tools used for neurological assessments include Glasgow Coma Scale (GCS), measures consciousness levels and response to stimuli. National Institutes of Health Stroke Scale (NIS) assesses the severity of stroke symptoms based on clinical examination. Mini Mental State Examination (MA) evaluates cognitive function and orientation. Functional Independence Measure (FIM) measures a patient's level of independence in daily activities. What role does patient education play in the context of primary prevention of strokes, and what key topics should be included in educational programs? Answer: patient education is pivotal in the primary prevention of strokes by equipping individuals with the knowledge to manage their health proactively. Key roles include empowerment. Educating patients about their health conditions and risk factors encourages them to take charge of their health. Awareness of risk factors. Informing patients about modifiable risk factors such as hypertension, diabetes, smoking, and sedentary lifestyle. Importance of regular health screenings. Stressing the need for regular checkups and screenings to monitor blood pressure, cholesterol levels, and diabetes management. Key topics to include in educational programs are nutrition, understanding the impact of diet on cardiovascular health and stroke risk, exercise, promoting regular physical activity and its benefits in reducing stroke risk, smoking cessation, providing resources and support for quitting smoking, a major stroke risk factor, medication management, educating on the importance of adhering to prescribed medications to control risk factors.